let me introduce myself, and actually not myself, let me introduce the channel. Channel is Medical Perspective. Here we are discussing various topics that are board related as well as medical relevant. Now, if you are online, let me know your name in the chat box. Having the name in the chat box will make the course more interactive. It is also important to adjust to the feedback that you're giving. Okay, we will start in the next 60 seconds to discuss what are the best next steps. This is a frequent question seen with Step 2 CK vignettes. What is truly important at this question is to have an algorithmic thinking. Okay, we'll start off by discussing about a 20-year-old pregnant woman. She actually gives birth to a boy of around 4,300 grams. Her last oral glucose tolerance test showed somewhere around 232 milligrams per deciliter for the glucose level. The neonate has a murmur at the left sternal border between S1 and S2. What is the best next step for the cardiac defect this infant has? A. Reassurance and observation. B. Surgery switching the heart's main vessels. C. Prostaglandin E2. Or D. Bosentan to reduce the pulmonary hypertension. The correct answer to this question is actually A. Reassurance and observation. Firstly, if we have the transposition of great vessels, which would require surgery switching of the main vessels, we will have a louder S2 due to the aorta, a louder S1, sorry, due to the aorta being ahead of the pulmonary vessel. But we would not have a murmur at the left sternal border. Also, if we would have pulmonary hypertension, then the patient would have a louder S1 due to pulmonary closure that is louder, a louder S2 due to pulmonary closure that is louder. The patient would be given prostaglandin E2 again if we would have a cyanotic cause. One such cause could be tetralogy of Fallot. Now, our patient actually has hypertrophic obstructive cardiomyopathy. This is typically seen in pregnant patients that had gestational diabetes. In this case, the pathogenesis is caused by the interventricular septum that actually gets filled with glycogen and fat deposits. These deposits will consume the cells up until the 1 year old threshold of the patient, and thus the infants do not require treatment. Okay, are there any questions on this topic? The next question revolves around a patient from a motor vehicle accident. He has abdominal tenderness with a rigid abdomen. His vitals show 100/50, 120 beats per minute, and 36.4 degrees Celsius. His labs show a hemoglobin of 7 grams per deciliter, a creatinine of 1.4 milligrams per deciliter, an ALT of 100, an AST of 90, a CK of 600, an LDH of 400. The anesthesiologist is reluctant in inducing the patient with succinylcholine. What is the contraindication seen in this patient to succinylcholine? A. Severe hemorrhage, B. Liver injury, C. rhabdomyolysis, or D. Organ failure. The contraindication for this patient is rhabdomyolysis. There are some situations when succinylcholine is contraindicated. Rhabdomyolysis, and we will discuss a little bit after why rhabdomyolysis and some other causes are contraindication for succinylcholine, or the upregulation of acetylcholine receptors. The situations with this type of upregulation include denervation, Guillain-Barré syndrome, and burn injury. In these two specific cases, the anesthesiologist usually employ non-depolarizing agents such as vicuronium. Now, let's discuss the mechanism behind succinylcholine being contraindicated in rhabdomyolysis. Okay, so for a start, here is succinylcholine. At the cellular level, actually, succinylcholine, okay, this is not that representative of a cell. Great, let's draw the nucleus as well. Now, there are two types of channels. Okay, these are channels that allow the influx of sodium, the natural influx actually of the sodium, and the natural efflux of potassium. So here we have potassium, and on the other part we have sodium. Now, the effect that succinylcholine has on each one differs. What it does is to potentiate each one of them, meaning it increases the sodium channels that are opened and increases the opening of the potassium channels. The end result is that there is an increase in the extracellular potassium. And this very well will lead to this in turn will lead to hyperkalemia. Hyperkalemia is arrhythmogenic, so we don't want to have a patient that on the operating table becomes pulseless, namely has a cardiac arrest. In regards to the situation of rhabdomyolysis is also a condition that is associated with high potassium extracellularly due to its release from the intracellular reserve when the cell is destroyed. There are also other conditions that contraindicate succinylcholine. The next clinical vignette is about 63-year-old patient that comes to the ED for confusion. He got a sore throat and a cough from his niece 2 weeks ago. She came to trick or treat after having a doctor appointment for a sandpaper-like rash. The patient's creatinine is somewhere around 2.5 for baseline of 1.7. What is the best next step in this patient? To administer an IV saline, to determine the electrolytes, to do a urine analysis, or to prescribe ampicillin? In this case, the answer is C, to perform a urine analysis. We perform an urine analysis as we have signs of acute kidney injury with a baseline that was disturbed with more than 0.3 milligrams or 30%. Now, we have a suspicion of PSGN because we have hematuria and proteinuria if this is what the urine analysis shows. How do we implement the algorithm of ACI? Okay, Then let's remove this part and talk about Aki. Firstly, we look for signs and symptoms of volume depletion. This could be easily translated in having a fractional sodium of less than 1% or more than 2%. If it is less than 1%, then we have a pre-renal cause. If it is more than 2%, we have a renal cause. Now, clinically, we can just take a look and see if the patient is dehydrated. And you practically have the yes case and the no case. So if he's dehydrated, then we consider an IV saline. He's not dehydrated, so we have no signs. Then we do an urine analysis and a urine culture. Now, there are three main results for three renal pathologies frequently seen with Aki. Okay. If we have granular casts, then we start thinking about acute tubular necrosis. If we have hematuria and proteinuria, then this is a definite vote for glomerulonephritis, as our case happens to be a type of glomerulonephritis, namely post-streptococcal glomerulonephritis, as his niece had a sandpaper rash. Okay. And there's one more case when we have sterile pyuria. Sometimes we might have also eosinophiluria as well. Okay. For this last case, not a good starting point. Okay. For this last case, we consider acute interstitial nephritis. Usually it will be seen in cases of patients taking NSAIDs, patients taking cephalosporins, patients taking penicillins. Okay. So this is a simple algorithm that you can employ whenever you have suspicion of ACI. Well, that's all, folks, for today. Thank you for being here. And if you have any questions, let me know in the description. Also, if you have subjects that you want to debate on the next live stream, let me know in the comments. Finally, leave a like if you enjoy this type of content.